Hello, good afternoon, everyone, and thank you so much for joining us for today's webinar, Hunger and Health, Exploring Challenges and Opportunities in the Food Policy Landscape. My name is Haley Aka. I'm Vice President of Operations and Strategy at the Health Policy Institute of Ohio, and we're so grateful that you all can be with us today. HPIO is an independent and nonpartisan organization. Our mission is to inform data-driven policies that improve health equity, and the value of healthcare spending. We'd like to extend our gratitude to our core funders who advance our mission with their steadfast investment in our work. We also want to give a special thank you to Arnold Ventures, who is the presenting sponsor for this year's educational event series, as well as our education series sponsors for their generous support of our events. Today's presentation slides will be available on the HPIO website. They can be found by following this QR code or by heading to the HPIO website and clicking on the Events tab. So as our speakers are presenting today, please feel free to type any questions that you have into the chat or into the question box. I'll be monitoring those and we'll address them as time permits. We'll also have some poll questions for you at the end of today's session, so please stick around for those. All right, I would like to start our conversation today with some data out of the Health Value Dashboard. The Health Value Dashboard is a collection of tools and resources that compare Ohio's performance to all other states on health-related measures. And in this latest edition, which was released just a couple of months ago, we found that Ohio ranks worse than most other states on food insecurity. 12.8% of Ohio households did not have adequate food due to lack of resources in this most recent data set. And Ohio ranks 37th on this measure, which is worse than most other states in the country. Ohio also has higher rates of some nutrition-related chronic diseases, ranking 35th in diabetes and 38th in hypertension. The current federal administration has expressed a significant interest in this connection between nutrition and chronic disease prevention. Through messaging related to the importance of healthy lifestyles, the Make America Healthy Again initiative, an updated set of dietary guidelines, the federal administration has communicated an interest in nutrition, food production, chronic disease prevention, and childhood health. At the same time, the president signed a federal reconciliation bill known as H.R. 1, sometimes called the One Big Beautiful Bill Act, into law in July of 2025. H.R. 1 has created a series of barriers to funding nutrition supports and treating chronic disease. One example is funding restrictions in the SNAP program. SNAP, the Supplemental Nutrition Assistance Program, is a federal program that provides individuals and families with low incomes with financial support to purchase food. 12% of Ohioans were enrolled in SNAP in 2024, representing 1.3 million people. H.R. 1 made several changes to SNAP that affect eligibility and program administration. For example, H.R. 1 shifts more program costs from the federal government to the states. Because of this, Ohio's share of SNAP costs is projected to increase by an estimated 268% once H.R. 1 is fully implemented. This means state and local policymakers will face decisions about how to manage these costs and implement changes to the program, which could include cuts. H.R. 1 made other changes to SNAP, like expanded work requirements and changes to eligibility based on immigration status, which will have the effect of serving fewer Ohioans through SNAP. Medicaid is a public program that offers health insurance and other services to groups experiencing economic disadvantage. There are about 3 million Ohioans being served by the Medicaid program. Not only is Medicaid coverage essential for treating chronic disease among eligible Ohioans, but there are several ways in which the Medicaid program can be and already is being used to provide nutrition supports in Ohio. H.R. 1 is expected to result in a loss of $33 billion in Medicaid funding over the next decade for Ohio, which will likely cause losses in coverage up to 340,000 enrollees, according to the Congressional Budget Office. There are several policy shifts in HR 1 that lead to this decrease, including the implementation of work requirements for the Medicaid expansion group, more frequent review of Ohioans' eligibility for Medicaid, and new restrictions on provider taxes, which states use to generate revenue to pay for Medicaid expenditures. Those are just some examples of changes to Medicaid over the last year. These funding cuts come at a time when many Ohioans already struggle to pay basic expenses. In 2023, more than 1 in 4 Ohioans had trouble paying for their usual household expenses, and we expect that number to increase in the years to come. The purpose of our conversation today is to examine the changing policy environment related to nutrition and chronic disease, these state funding pressures, and individual financial challenges, and explore the opportunities that still exist to address hunger and improve health in this landscape. And we're so grateful that you all are able to join us for this conversation. HPIO has produced a number of publications on recent federal and state policy changes. If you want more on any of the policy changes I briefly shared, you can find those publications on our website or by scanning this QR code here. I'm also happy to share my contact information if you'd like to connect on any of the things that I briefly mentioned. With that little bit of opening remarks, I'm going to transition to our first speaker, who will orient us to some nutrition work happening in Ohio, and who will also be moderating our panel conversation today. Grace Wagner is the Director of Health Initiatives at the Ohio Association of Food Banks. I'll show you all her slides. And Grace is in leadership over or involved in many statewide initiatives at the intersection of hunger and health. And I'm so grateful that she's able to join us today. So thanks, Grace.
Thanks, Haley. I think I've got my laptop back working. You love tech issues, but if not, I will rejoin on my phone. Hi, everyone. I'm Grace Wagner, the Director of Health Initiatives at the Ohio Association of Food Banks. If you go to the next slide, Haley. Just a little bit about the association. So we are Ohio's largest charitable response to hunger, and our mission is to assist and represent Ohio's 12 Feeding America food banks in providing food and other resources to people in need and to pursue areas of common interest for the benefit of people in need. Next slide. So Haley shared a wonderful, state of things is not wonderful, but a really great overview of some of the federal changes that are happening, both to SNAP and Medicaid, and the interest at the federal level, the growing interest and recognition that, nutrition and health outcomes are connected. I don't know that that's news to anyone on this call, but there's growing recognition and federal interest to support that. And there's been a number of federal and state, local studies to show this. I'm highlighting one from the USDA from 2023 that shows the connection between, households that have the presence of food insecurity and a variety of chronic conditions ranging from hypertension, arthritis, diabetes, stroke, just to name a few. There's also been studies that show the linkage between persistent food insecurity and certain types of cancers, and other metabolic diseases. And this also plays out in Ohio. Every couple of years, we do a survey of individuals that are accessing the emergency food system. We call it the statewide hunger study. And so I've also copied a couple of results from our 2024 study, just to highlight a few. Of the individuals that were surveyed, at least 34% indicated that a member of their household had high blood pressure. 24% stated that one member of the household had diabetes, and 12% stated at least one member had a form of heart disease or stroke. And we know that, with the presence of food insecurity in a household, people are often making decisions, really tough choices about affordability, and about, more than half of individuals that access the food pantries that year reported making choices between affording food and affording medical care. Next slide, Haley. So you may have heard of a concept called food as medicine. Again, this is kind of growing in national and state recognition. And what food as medicine means is it's just trying to bring healthcare and healthy food access closer together. It's really that connection between someone's health and their healthcare systems and their nutrition and food access. And there are interventions that exist along a spectrum, at the base of the pyramid, we can think about the population level, food policies and programs that are supporting community health. And then as you go up the pyramid, as someone maybe has higher acuity, higher need, you can think about providing, short-term, medically tailored meals that are individualized to that individual's condition that support their overall health. And along with that, there's engagement with the healthcare system through nutrition counseling and education as well. Next slide. Just to touch on a couple of things that are happening in Ohio. This is by no means a comprehensive list, but just to give you a sense, this work is really rooted in cross-sector collaboration. We have a really strong history in Ohio of working across sectors, like healthcare, agriculture, community-based organizations, and coming together to think about how we want to advance statewide work. Some of that has been led by HPIO in the past, and built the foundation. So even though there are, many changes coming to SNAP and Medicaid, both in Ohio and nationally, the good news is that we have robust assister networks that exist both within the food bank network and with external partners, federally qualified health centers, community health centers, just to name a few, hospital systems that have individuals that can navigate someone through the process of understanding both how to apply for SNAP and Medicaid, the changes that are coming, and how to keep coverage when eligible. There's a few coalitions. There's the Community Health Collaborative, which is led mostly with our Pathways hubs that support community health workers across the state, and our AAAs, which serve senior populations. There's the Ohio Food as Medicine Collaborative that I'm lucky enough to co-lead with our partners, Produce Perks Midwest, that I'll talk a little bit more about in a moment. And then there's some really great work happening with our Medicaid managed care plans, thinking about how to leverage community reinvestment to support community needs. There's a variety of topics on the table, one of which is supporting community nutrition, which is really exciting. Next slide. So just to come back to the Ohio Food as Medicine Collaborative, this is a this is a collaborative that it's almost a year old now, which is which is wild. We started in October of 2025. We had our inaugural meeting. Our panelists later represent some of the steering committee for that group as well. And it's really thinking about, again, that cross-sector collaboration. How can we bring together partners from across food and agriculture, healthcare, managed care, all sorts of, state and federal partners, and promote sustainable system change and financing interventions for food as medicine. Like I said, it's thinking about, individuals that are growing the food or local, state, regional producers, community-based organizations, healthcare organizations, and we're excited to have some state agency partners as well. Excuse me. I think that may be my last slide. Yep, my contact information is on the screen here. Please feel free to reach out anytime. I'm happy to share more about some of those initiatives that I briefly highlighted, or just connect around this work in general. And with that, I'm really excited to transition to our panel discussion. We have some really great speakers with us today who can share their perspective on the work that is happening. Excuse me. We have Adrienne Mundorf, who's the Director of Business Development at United Healthcare. We have Kristen Matlack, who's the Manager of Social Care Initiatives with Metro Health. We have Debbie Serenius, who's the Director of Healthcare Partnerships at Produce Perks Midwest. And we have Shane Benton, the Food Access Manager with Rural Action. Welcome, everybody. Give you a moment to get your cameras on. Hi there. So we're going to start out with just some brief introductions. If you wouldn't mind introducing yourself, your organization, maybe tell us a little bit about how the food as medicine initiatives that you implement or support are improving health outcomes and addressing food insecurity with the populations that you serve. Let's start with Adrienne. Let's go alphabetical.
All right. And I'm also having technical difficulties, so hopefully my sound and video is coming in okay. Hi, everyone. I'm Adrienne Mundorf. I'm a Director of Business Development for United Healthcare. And while my role today gets to touch on food access and nutrition, I've been working across various sectors in food access, food security, nutrition, and hunger for about 25 years across a lot of different sectors, and really got the chance to bring that knowledge and experience to the role I have today. I currently serve across several markets that where we have United Healthcare community and state programs where we serve our Medicaid and dual eligible Medicaid and Medicare members. And I have the opportunity to support strategic partnerships and community investments in those markets. But just previously, just stepped into this role in the fall. I worked for the Ohio Health Plan for United Healthcare as the Health Equity Director and led SDOH initiatives that a lot of which included collaborating with community partners to address disparities in food security and drive towards improved health outcomes. When we sort of take a step back and look at the United Healthcare community plan as a whole, we approach food as a clinical intervention and not just a social support, especially for members with chronic conditions like diabetes, hypertension, et cetera. And we look to build a continuum approach. So really starting with screening for food insecurity, connecting members to community resources, and delivering targeted and appropriate programs like medically tailored meals. And I'll share a couple of stats that I think sort of ground us on. We heard some stats earlier, and then looking even more broadly, about 25% of our Medicaid members that have been screened across the country have a nutritional need. And we've just sort of give you what a sense of that looks like. 8 million members have screened for food insecurity, and we've been able to connect about 70% to local food resources. And across the country, we support about 13 food as medicine programs. I'll give you a couple of examples of those, I think now, Grace, before we move on, just to give you a sense of what we're thinking about with food as medicine. And again, getting back to what's most compelling is really that clinical impact. We've got a couple of programs that are diabetes focused nutrition programs where we've seen reductions in A1C, weight loss, reductions in ER utilization, and improvements in total cost of care. One example in Nebraska, in the community surrounding Omaha, we were able to support a nutrition intervention that paired together an FQHC and several community-based organizations who provide local food access and nutrition education to be able to address food insecurity and lack of healthy foods. And the approach focused on taking the FQHC's diabetes prevention program and then layering in supports, including medically tailored food boxes that were supplied again by local farmers, healthy recipe cards, and then cooking classes that use those food box ingredients. And then the remaining CBO partner tied in gardening classes for growing and cooking their own healthy foods. We saw a great impact through that program. We saw a 2.1% reduction in A1C within 6 months, and 100% of the individuals that participated in that were maintaining or improving their diabetes risk level. And it even had an impact on weight reduction, an average of 4.3 pounds in weight reduction. We've got a couple of Ohio examples, but maybe I'll give some space for others to chime in where we've had the opportunity to again partner with community organizations and really drive towards improved health outcomes and increased utilization of appropriate services like well visits and immunizations. So I think just bottom line, addressing food insecurity stabilizes members, and food as medicine programs goes that step further. We're improving long-term outcomes and reducing avoidable utilization.
Well said. Thanks, Adrienne. Debbie, do we want to transition to you?
Sure. Hello, everyone. I'm Debbie Serenius. I'm a registered dietitian and the director of health partnerships at Produce Perks Midwest. Our organization operates nutrition incentive programs across the state. So, Grace, I was really glad you showed that food guide or the pyramid in your opening remarks, because it's important that we realize, SNAP and other population level programs are the base of that pyramid. Important to note that FEM services, across the board have their place in our food safety net. Our Produce Perks SNAP matching program stretches that SNAP dollar and incentivizes fruit and vegetable consumption. Produce Perks has been implementing produce prescription programs, which we call PRX, for about 8 years now. In 2018, we implemented our first program in a general practice physician office with his patients that had hypertension. Fast forward to today, we currently offer programs focusing on maternal health and diabetes populations. So with our maternal health PRX, it supports the mom and the whole household health and seeks to improve birth outcomes, specifically gestational age at birth and the weight of that infant at birth. And our diabetes programs support improvements in A1C and weight. And Adrienne, across the board, we've seen improvements in these measures, which have been very encouraging. And another statistic that I like to share with people is one of the things I'm most proud of is that, when we survey and do some of these qualitative measures at the end of these programs, over 90% of our participants say they plan to keep up with the healthy behaviors that they've learned within these programs, because we're supplying also, cooking tools and some of that nutrition education. And that's what we want, is that sustainable behavior change, right, to keep them healthy. And just another important point, that both food security and nutrition security, they're both important. People need enough to eat, and they need access to enough healthy foods to impact their health. We know nationally that folks increase their fruits and vegetable intake on all of these programs, thus leading to better health. In fact, according to the most recent GusSNAP NTAE findings, and I'm going to quote, the participants consistently reported increased fruit and vegetable intake. Specifically, produce prescription participants showed significant improvements in blood pressure management, blood sugar regulation, when all of these point to potential healthcare cost savings, which I think is something in the climate that we're in, we need to pay attention on how we convey that message of the cost savings.
Great. Thanks so much, Debbie. Thanks for being here. Kristen, I'll turn to you next.
Good afternoon. I'm Kristen Matlack. I'm the manager of social care initiatives at the Institute for Hope at Metro Health. Metro Health is the public safety net hospital system serving Cuyahoga County and surrounding areas in Cleveland, Ohio. And the Institute for Hope oversees our work associated with screening for and addressing the social drivers of health. And my work specifically focuses on the intersection of food insecurity and health, much like Grace's work. So we at Metro Health have a variety of programs across that food as medicine pyramid or spectrum that Grace shared, starting with screening for food insecurity among our patients, and then connecting them with Emergency Food Network, connecting them with community-based food programs, getting them enrolled on benefits that they're eligible for, or other programs that they might meet eligible criteria for, like if in the aging population, getting them home delivered meals, things like that. We give away thousands of meals of free produce a year to our patients and community members. Our flagship program is our Food is Medicine Clinic, which is a medically tailored grocery program. It's been running for about 8 years now. And that is focused on patients who are food insecure and who are struggling to control their diabetes or hypertension. That's been quite successful. They're eligible to come every 2 weeks and shop for healthy foods for their entire household. And they also receive nutrition counseling. We've been able to demonstrate significant changes in increasing healthy eating behaviors, decreasing food insecurity, decreasing A1C and blood pressure, and decreasing cost, largely through avoiding admissions. We've also done medically tailored meal pilots in the past, and one I want to call it in particular was focused on high-risk patients who had multiple chronic illnesses impacted by diet. And we provided 6 months of medically tailored meals at 10 meals a week, and those showed significant cost savings of more than $1,400 per member per month while they were participating in the program. So I'll turn over to Shane next, I believe.
Kristen. Hi everyone, my name is Shane Benton. I'm the Food Access Manager with Rural Action out of Ohio. I joined this team in 2022 as the Food Access Manager, and one of the programs that I run is our PRX, which falls in the middle of that food pyramid. In that year, when I first joined, we were doing about 300 patients for a 19-week program, which our programs are generally about 19 weeks. Hold on, I'm going to switch something. Is that better?
Yes, thanks, Shane.
Does that make it better?
Perfect. You're muted now.
Now, is that helpful at all, you guys?
Yes, that's wonderful. Thank you, Shane.
Okay, cool. Sorry, I apologize. Again, Shane Benton, Food Access Program Manager with Rural Action. Joined the team in 2022. We are doing about 300 client patients on a 19-week program. And over the years, it's been partnerships with a variety of healthcare providers, from Hopewell Health to the Copeland Health Systems and Marietta Memorial. We do nutrition classes paired with food. This past year, one of the things I'm most proud of is we did a 9-month pilot in partnership with the Southeast Ohio Food Bank. With all of our food access programming, and especially our PRX, we really emphasize sourcing and utilizing local produce from local farmers. So always helping our local ag economy through these programs, while at the same time helping our people in our communities by providing the food that's grown in their communities. A lot of these programs, again, 19 weeks of food, but then additional weeks of classes, community, and kind of building those relationships that last, because we are looking for lifestyle change. And that takes more than just a food drop or some information here and there. People want to talk about the food they're eating and appreciate it and enjoy it. So the community component has always been really important to the success of these programs. And again, it's a great opportunity to look at our local food system and how to strengthen it and help our local farmers while supporting our local community members.
Cool. Thanks, Shane. Really impressive work happening across all your organizations, and I'm honored and happy to be on the panel with all of you. I'm going to transition us a little bit. Haley teed up the federal landscape and some of the federal changes. But we also have heard that there's been growing interest in food as medicine at both the federal and state levels, and chronic disease prevention. Excuse me. What opportunities do you see for expanding these initiatives in Ohio, and what policy or financing barriers are needed to be addressed? And I'll open it up to anyone who wants to start.
I'll go ahead. I will say that there's nothing but opportunity here. All the recent chatter about this is very exciting for those of us who've been doing this work for a while. It's bringing new partners to the table, And the more awareness and interest there is, the easier it is to get these things financed, right? But right now, I would also say, as far as financing barriers and keeping these programs sustainable, it's currently really piecemeal. It's a lot of pilot programs, and it's been funded primarily through like limited and non-renewable funding streams thus far. So we need to shift towards a policy that would support food as medicine initiatives as covered services for patients, those particularly with diet-related chronic diseases who we know this is having an impact on, so that we can provide it on a more consistent basis to make real change.
Nicely put, Kristen. So yeah, and I think it's just kind of important to note that currently at the state level, there's not really a policy pathway to embed these FEM services into healthcare for Medicaid participants in Ohio, because that's the goal we're all shooting for, is to reach that population with these services. However, there are pathways available, which many of us are pursuing outside that policy, like partnering with MCOs through value-based services, community reinvestment fund opportunities. And the Ohio FEM Collab, shameless plug here, is trying to bring healthcare and service providers together to work on how we can do this with standardized and scalable models. So we're kind of all on the same page with this. Looking at other barriers, I mean, like the in lieu of services seems to be perhaps a safer policy pathway in the current political climate that might be something to pursue. The Ohio FEM Collaborative is meeting with neighboring states like Michigan and West Virginia to learn from their FEM implementation paths. And just for an example, like Michigan passed IOS, but wasn't fully prepared for enacting those services. So we're trying to have those systems in place so that we're ready for any policy change, that all of us can participate in. And of course, there's always a financial barrier, right? The cost of building capacity for CBOs to be ready to accept referrals, figuring out that interoperability tech so that there can be communication between healthcare and CBOs, providing the FEM service, and trying to figure out how this can be addressed statewide or at least regionally accomplished. So, and then of course, solving for how we enable these smaller CBOs to participate.
Yeah, I'd say ditto to everything that Kristen and Debbie just said. And I think I saw in the chat a little bit ago, someone was asking for an Ohio example from me. And I'll sort of tie that into some of the existing policy structures where we've been able to partner with community organizations. So the example I gave from Nebraska was leveraging community reinvestment, which we also have available in Ohio. The requirement is really around pooled funding, and Grace alluded to some of the collaboration that community-based organizations and managed care organizations are having to identify what those funding opportunities can look like to support community nutrition. And then some MCOs, United Healthcare included, did an incremental above and beyond community reinvestment and has been able to make some strategic investments, sort of getting to that infrastructure that Debbie mentioned, building the infrastructure, particularly with Ohio Association of Food Banks, and taking a food pharmacy intervention that Mid-Ohio Food Collective has been running for several years in partnership with providers, and leveraging that for managed care organizations, for our care managers to be able to refer our members as we identify those needs for completing health risk assessments, for I hope I'm still there.
You're here, Adrian. Yeah.
Okay. Good. And then so taking that, so there's that interoperability between a managed care organization and a network of food banks, and then also scaling that not just within Mid Ohio's footprint, but also in Northeast Ohio and Southeast Ohio. So that work is underway as an example of a community reinvestment. Another mechanism which is currently in place now is, given the Ohio Department of Medicaid's emphasis on population health and quality, there's the ability to explore pilots through that really get to meaningful health, population health improvements. So another example where it's a little bit more on the food insecurity side, but we've been able to see improvements in quality measures, is a partnership with Childhood Food Solutions in the Cincinnati area, where we've been able to identify families at risk of food insecurity, again, through that health risk assessment, and then deliver monthly food boxes to those members, so that we're one, it's our care managers and our CHWs that are making those connections, and then aligning those food resources with health education materials and promotion of healthy habits to get folks in for immunizations, dental visits, well care visits. And we've seen improvements in well care visits, 7.5% increase there for ages 3 to 11, 16.7% improvement in ages 12 to 17, which as a mom of a tween, I can tell you it's really hard to get your tween to the doctor, as well as a 25% improvement in immunizations and same improvement in dental visits. So I think that's another example where there already are mechanisms in place. And then the third one is value-added benefits. So that's an area where we partner with an organization called Mom's Meals to deliver medically tailored meals to individuals who are postpartum or post-hospital discharge, to give them those wraparound supports for those couple of weeks as they're recovering back at home. As Debbie said, though, I think a lot of those mechanisms need to be piecemealed. And again, a pilot is exactly that. It's a pilot. It's not something that can be sustained. And where I think, sort of thinking about some of the barriers to get to some of those sustainable financing, like value-based care arrangements, making sure that billing and reimbursement infrastructure is there, potentially advocating for in lieu of service. I think Haley put in there ILOS, in lieu of services. So that would be sort of making a proposition that by providing healthy food resources, medically tailored meals, produce prescriptions, to individuals that might be at high risk for chronic disease conditions, or aren't managing their outcomes, that we can that those are more affordable ways to deliver health care is through food, and that can diminish the need for ED visits or inpatient stays. So I think where we're really working to try to impact the field is taking those pilots and really understanding, well, what's the total cost of care impact? What's the impact on quality? Where do members see value, so that we can embed those kinds of pilots into existing partnerships that we have with providers through value-based care, really incenting for those improved health outcomes and cost savings. Shane, you might have something to add there too.
I mean, that was all very comprehensive from all of you. I would think, just to reiterate what Kristen said, there's nothing but opportunity right now. There's a lot of traction, a lot of conversation happening. I think it's important to let people know it exists and get it out there so that they can have conversations with their healthcare providers to inquire about it, just to keep the buzz going. The administration is, there's a lot of conversation around the MAHA movement and getting healthier diets as a means to treating promoting healthy outcomes. So I think that this is the time to strike, if you will, and us all talking together and building relationships keeps us ready for it.
Yeah, really well said, Shane. And that leads into the next question I wanted to ask, and maybe we'll stick with you, Shane. As these changes are coming to SNAP and Medicaid, both for Ohioans and nationally, how can we work better together to maintain access and support health, both from food producers, healthcare, community organizations, etc.?
Yeah, no, that actually was a really good segue because it's talking to each other and building relationships. I saw it in the chat. We mentioned earlier there's different organizations around the state meeting up in Northeast in Cuyahoga. There's a lot of opportunities for assistance. There's a group meeting regularly. So talking to each other to see what people are doing, what people want to be doing. Right now we're partnering with Marietta Memorial, the Hopewell Healthcare System, Copeland Systems, and everybody is doing something a little bit differently. And so I don't think it's a one size fits all, especially when you're looking at rural versus urban areas. I think letting communities decide what is the best for them is really important. Listening to the people in the community. I saw one of the people mentioning we're really trying to increase participation. What can we do? I can't always tell you that, but the community members can. Ask them, is it transportation barriers? Is it barriers to finding the food? Is it, there's no food I like, it could be a litany of things, but the individuals participating in these programs can inform us on the direction of these programs. And I think that's a great direction to go. But again, going back to building community, listening to members in the community, listening to your healthcare providers, what they want to see in programs, what do the funders want to see? It's a lot of talking and listening that I think is important.
Yeah.
Oh, sorry. Go ahead, Adrian.
Yes. And I think it's really that understanding of no single sector can solve food insecurity, right? It takes an unsiloed approach, and just huge gratitude to Grace and Debbie for starting and keeping the momentum for the Food is Medicine Coalition. There was an incredible in-person convening last month that was just such a great example of what that means, bringing together diverse sectors for learning, relationship building, which is probably the most important part, and then networking across those silos to make a bridge. I think another promising direction as we think about collaboration in Ohio is, and I don't know where we stand, I think we're finding out in a couple weeks that jointly Ohio Department of Health and Ohio Department of Medicaid submitted a proposal for a 3-year Food is Medicine coordinator position to sit at the state and really bring some of that deep bench and state level coordination and collaboration capacity to further align partners and really bring that seat to the table. So I think we'll find out soon. I think that's going to be a huge impact on this work in Ohio. And then I think it's really understanding when you get down to individual partnerships, like Shane was mentioning, each is so unique and there's different components that each partner might be bringing to the table, but really understanding what those roles and responsibilities are for the CBO partner, for the provider partner, for the payer partner, and what those clinical pathways look like, so that we've got that connectivity between all of those players to be able to make sure that we're bringing, the individual receiving those supports a seamless experience, but then also, again, on that back end, what is that data, what does that outcome look like, and making sure that it's getting to those outcomes on total cost of care, on improved quality, so that we're able to make a case for that sustained funding.
Yeah, agree. I think we're all on the same page on this panel, but I think, what Shane and Adrian have touched on is, I think those shared learnings between us FEM service providers is really key, right? How can we standardize, build, support the already existing work. I think what's been encouraging with the FIM collaborative is the appetite for all of our organizations to want to start working together, which I think, a few years ago, those of us have been in here a while, maybe wasn't there. So I think learning from each other and how do we build on what the work is already going on, and learning what, I'm excited for some of these mapping projects that we've seen, the Ohio Department of Health is doing, like what is actually going on. I'm learning all the time of programming that I wasn't aware of, through some of our members, which is really exciting. Yeah, and just encourage anyone that isn't already involved with the Ohio FIM Collaborative to reach out to Grace or myself. We're having a meeting tomorrow. So just if you'd like to join that and learn more about that work of trying to come together, what's going on.
I would co-sign all of that. I would also, on the theme of communication, I would encourage us, specifically as it relates to the changes to Medicaid and SNAP, to communicate more broadly outside of our usual contacts. And an example, a personal story that got me thinking about this is I have a personal friend who's a pharmacist at Giant Eagle who just over like a holiday barbecue happened to say, like, what's going on with Medicaid? People, like, when I go to fill it, they're not covered. They're dropping at a higher rate. So we're thinking about how to handle this, as healthcare providers sometimes, like when they're coming to a visit and they're dropped, or we're thinking about how to reach people in the emergency food network, right? And making sure that what we're already doing is loud and known to people, and we're trying to get them to the right resources. But we need to consider that maybe they're figuring out that their SNAP is discontinued when they go to swipe at a grocery store. And so could the grocery store possibly hand them the JFS flyer? And like the same with pharmacies that aren't affiliated with our exact networks. So I think we just need to communicate more broadly in general about these kind of things. And then people are going to drop off, as Haley shared with us. There will be people who will lose these benefits. And those of us that are running programs, can we consider how our program eligibility could be flexible to allow those people who lose benefits to continue to receive our services? And I'm seeing a lot of head nods. So like that wouldn't affect, like when we're doing programs and it's whether you're food insecure, that's not dictated by your benefit status. And so you would remain eligible. But when that's possible for us to do, if our funding source allows for us to consider just general income guidelines or food insecurity or hunger or nutrition insecurity guidelines for eligibility, so that people aren't losing access to our services as well.
Yeah, that's a really great point, Haley. And it speaks to a question we did get in the chat earlier, talking about, many people who are food insecure fall through the net because they don't qualify for these programs. And we know that food insecurity is not tied to a certain income bracket. Anyone can experience food insecurity at any time. And you just alluded to a really great idea about thinking about the eligibility for these programs, wondering if anyone else has thoughts about how do we still reach individuals that are food insecure but are falling through the benefits gaps or coming to a benefits cliff here in the coming months? Love your suggestion, Kristen, about really thinking intentionally about what is the eligibility for the programs that we're offering and what is the basis for that. Some of it is dictated by funding, but some of it is the presence of food insecurity and a clinical condition enough to make someone eligible for these programs? I would argue in some cases it is. Maybe in other cases, there's another layer that needs to be considered. But Debbie, Shane, Adrian, if you had other thoughts there.
I'll just jump in. A lot of us were recently in DC for the, FemCon conference, and this topic came up in a work group that I was in about, eligibility, specifically whether we include food security as an eligibility criteria, which of course all of us in this room, want to do. But there was some arguments that, the screening is not standard, so that could be something else we could look at. Folks are often embarrassed and don't answer those questions correctly, so they potentially could screen as not food insecure where they actually are. I think our organization has kind of taken the position that, we let the provider decide that because they know their patient better and might know that specific family situation. But I think it's a really interesting topic. And that work group that I was in a few weeks ago just really illuminated that I don't really understand all that there is to this topic, and it's a lot more complicated. But again, I think, if we as a state kind of work to standardize some of these things, so we're all talking about the same thing, I think that's a first step.
Yeah, and something you said earlier in the panel, Debbie, has stuck with me. There's a place for food insecurity and nutrition security, and they're both important, and like they're not mutually exclusive. Oftentimes they go together, but programs exist along a spectrum and can support a spectrum of needs as well. We have about 5 minutes left in our panel. Excuse me. So maybe let's do this one rapid fire and then turn it back over to Haley to close us. I can't believe we're already at the end of our time together. You know, if there's one thing that you or your organization is doing right now to prepare for these upcoming changes, and to continue to build the momentum for food as medicine, please share.
The one sentence version is we're trying to contribute to by providing strong evaluation of our programs to create the compelling case for policy change. So we all know, like, if somebody identifies as hungry, you feed them. It's the right thing to do. We're trying to also prove that it leads to better health outcomes and cost savings for all the partners, and to make that extremely compelling case.
You stole mine, Kristen, but I'll
A shared goal is great.
I know, that's right. That's what this is all about. We've recently partnered with American Heart Association, and are investing in some of their work that they're doing to really bring the evidence to the table that is not only going to drive at policy change, but also make the case for payers and investors on that exact point, like getting that improved health outcomes and driving at cost savings.
Say on our end, it's meeting regularly with people across sectors to see what everyone has in mind, and then currently writing us a proposal that shoots for the moon and is scalable. Go big, but keep it scalable. So if someone's like, oh, 100 is too much, we can do 10, we can do 20, we can do 30. Have it ready to go, because a lot of funding opportunities seem to be coming with these short windows. It's like, here it is, get on it. And so get your ducks in a row, talk to your partners, get your pieces in place. I would say right now, if I had unlimited funding, I have no issue finding like medical professionals who want to refer people. Like, they're always like, how many slots do you have? So keep talking to people, build those networks, and get ready.
I think we're all doing a lot of the same. Standardizing our programs, we're updating systems, adding staff, deepening partnerships. And we had a big diabetes GusNIP produce prescription project, and looking like there will be something published in a CDC journal, which we'll share out. So just, kind of getting more of that evidence out there that these programs are effective and needed.
Wow. Really wonderful stuff. Yeah, getting the evidence out there, because we have the evidence, we have our outcomes, and making it known in public. And Shane, I love what you said, being ready for when opportunities come, because I do think they are coming. And the more that we're collaborating and talking and ready to roll when these opportunities hit, the better served Ohioans will be ultimately. Last thing I wanted to say, I think I saw like 3 or 4 chats come in about this, how to get connected to the Ohio Food is Medicine Collaborative. Debbie shared her email in the chat. I'm going to put mine in the chat as well. Please reach out. Please reach out anytime, and we are happy to get you connected, get you on our email list, so that you can see what all the great work we have going on across the state. And, you know, as I said, we're a new group, about just over a year old or just under a year old. And so we're always looking to bring new partners to the table because we only know what we know. And there's a lot of great work happening that I don't know about, that we don't know about. So with that, I'll turn it back over to Haley. Thank you so much to all of our panelists. I learned so much from hearing all of you speak. I know we're in spaces a lot together, but it's truly, it's always wonderful to be with you and hear your perspectives. So thank you.
Yes, thank you all so much. It really was a treat to share this space with you guys. I have the opportunity to serve as part of the FIN Collaborative with all of the folks on the call today, and they were not exaggerating when they talked about the energy in the state around these shared partners. The collaborative effort that's happening cross-sectorally feels unique and special, and Grace's cat is telling us that it's time to wrap it up. So anyone who would want to get involved in the FIN Collaborative, I would say please reach out to Grace or Debbie. Okay, I'm going to share our deck just for a few closing slides. You know, our hope as HPIO and our webinar series overall is that this work would be informative to you and helpful to you in your effort to influence policy and improve health and well-being in our state. There's so many ways that you can influence policy, both as a private citizen and as a representative of your organization. We show this slide at the end to just jog your thoughts around some ideas to do that. And as we close out, we have a set of poll questions for you about how you plan to use the information presented on today's webinar, and then also a few brief evaluation questions. So my colleague Jasmine has thrown that poll. I would really appreciate you taking a look at that and scroll down, because there are a few questions there for you to respond to at the conclusion of today. There were also, I noticed, as you take that evaluation, quite a few comments in the chat where people were just wanting to connect or share. If you want to know each other better and connect, feel free to share email addresses in the chat. I'd be happy to make connections via email for anyone who does that in the chat today, so we can continue to build these collaborative networks related to food as medicine and nutrition supports and health in Ohio. All right. Thank you for continuing. Oh, great. Perfect. Thank you all so much. Feel free to keep taking that evaluation. Thank you for doing that. It really does matter for us as we plan these events and bring you information you can use for your work. And then I'll leave us here with HPIO's social handles. Please head to hpio.net if you're not yet receiving our weekly newsletters, and when reports and things come out, when invitations to webinars come out, we would love for you to join our newsletter so that all of that information gets to you. And then, yeah, you can follow us at Health Policy Ohio, all the places that you need us, and we will see you soon. Thank you all so much for spending the last hour with us. We appreciate you. Bye all.